Hi guys, welcome back to our YouTube channel. Well, my YouTube channel that you guys have decided that you love. And one of my friends was flattering me last week and he said that this is the best YouTube channel on YouTube right now. Anyways, I'm going to start by apologizing for not putting out a second video last month. I was a bit ill and I couldn't just bring myself to record a second video, but we're back. And today we're going to be looking at some common pitfalls in patient care and some of the ways we can address them as well. So stay with me and let's go. I think one of the biggest mistakes we can make as pharmacists is think that patient care ends with giving our patients the right medication. In reality, so many treatment failures occur even after the right medications have been given to the patient. And this occur as a result of gaps in like communication during counseling, failure to individualize therapy, and maybe even failure to monitor the patient, failure to assess the patient. Because I mean, this routine might work for this person and not work for the other person. So many things. A patient might be able to afford a drug and another patient might not be able to afford the drug, and you might not know these things if you don't properly counsel them. If you just give them the drug, they might never refill it. And these are like so many things that affect treatment outcomes. Like the popular example that one of my lecturers told me in school, that you cannot give a night guard a medication that makes you drowsy and tell them, oh, use it at night, because you just assume that it will make them sleep. Like people should be sleeping at night, right? So when you give a night guard a medication like tizanidine and you just give him and say, please use it at night, without telling them why they are using it at night, that, oh, use it at night because it will make you sleep, then they'll tell you that, oh, I'm a night guard, I don't want to sleep at night, I want to sleep in the morning. You can tell them to use it in the morning, right? But like imagine you did not tell them that and you just give them tizanidine, use it at night, and they go and be sleeping on duty. Do you want them to lose their job? Right. So that's actually one funny example that a lecturer gave us in school. And so we're just going to be talking about so many of these things today, and stay tuned, guys. Of course, the first thing I'm talking about is poor patient counseling. A lot of times we tell patients what drug to take. We don't necessarily tell them how to take it. Sometimes we do, when to take it, and most importantly, I noticed that a lot of people leave this out, how long. You find out that patients buy a drug and just keep refilling it. They keep coming to, if you work in community pharmacy, you know what I'm saying. They keep coming to your pharmacy with sachets of this drug because they used it the last time. They want to buy it again because they were not necessarily told how long they're going to be using it for. A lot of times, it's even like painkillers. You find out that the patient has been refilling diclofenac for as long as, fine, I understand that this patient might be in so much pain and might need to take these drugs from time to time. But what do you mean a patient is refilling diclofenac on and on and on and on and on and on? Do you get what I'm saying? So, like, we're going to be talking about poor patient counseling and an intervention that I made about 2 years ago, like in 2024. Yeah, 2 years ago, that has not left me since that day. So I was working in community pharmacy and a man with very severe Parkinsonism, like it was shaking, it was visible, like it was so bad. Very severe Parkinsonism, came to the pharmacy to refill his Cinemet, Levodopa, Cavidopa. He came to refill, and I mean, it was obvious that this man was faithful with using his medication, right? So he came to refill, and right in front of me, I gave it to him, and right in front of me, just moved to the waiting area, popped it in his mouth, and that was even very impressed with like his level of adherence. And I had other patients in front of me, so I wasn't necessarily paying attention to him. I was just attending to other patients. So I had finished attending to other patients in front of me, only for me to just turn and look at the man, and then I saw that this man brought out, he had even used it. He actually did bring out a bottle of antacid and took like 20 mils right after. I wasn't even paying attention. That's the thing. Because I had other patients I was attending to. By the time I paid attention to him, by the time I just looked to the waiting area, I saw that this man was still there. I saw him closing the bottle of antacid and returning it to his pocket. And I was very concerned. So I went to meet him. That, sir, Why did you take this antacid immediately with the drug that you just took? It was like, oh, that's how he's been taking it. He has ulcer. And I just felt bad. This man is actually very adherent with his medications, but he might not see any really good outcome with that anti-Parkinsonism drug that he's taking, because he keeps taking it with antacid like the same time. And I mean, you know what that you know what interaction would happen with that. The antacid is chelating to the drug is not being absorbed in the quantity that it's supposed to, and blah 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 is possibly happening. And this actually probably happened because the person that dispensed antacid to him at any point in the hospital or pharmacy did not emphasize that don't take this thing with any other drug. I know that this thing is very little and it's easy for us to skip it. I will not, no, I'm not categorically saying I will not, to paint myself as like a good person, but I don't think that anybody should dispense antacid without telling the patient that is taking it not to take it with any other drug. I know that it's easy to tell them, oh, take it 1 or 3 hours after food, take it this, take it that. It's important to tell patients not to take antacid with any other drugs, because even if they don't buy the other drugs right in front of you, you cannot be so sure that the antacid is the only thing they are taking. And if they are taking antacid at the same time with other drugs, the antacid is going to affect the absorption of the other drugs. Sorry, I think I'm shouting. But I was really sad on that day, and I just counseled the man properly. I told him that he should please not do it again, that this is what can happen, this is what it is, that it's almost as if he has been sort of wasting like part of the dose of the anti-Parkinsonism, and he should not take it at the same time together again and all of that. But that memory actually is like forever etched in my head, because I felt sad for the man. I was wondering how it was still, because he came to the pharmacy to buy his drugs. I heard from like people I work with that he always buys his drugs. He never defaults, and one would think that, I mean, Parkinsonism is not something that easily goes right, or like that is easily managed. But one would have expected maybe some level of outcome or improvement. But seeing as he has always been taking it with antacid, we don't know if that's why he has not seen like actual treatment outcome, right? So that's one. Another one that recently happened was one of my family friends calling me to tell me that, oh, she used 2 tablets of 400 milligram ibuprofen in the morning. Can she take another two at night? Now, this is it. So she's used to getting ibuprofen from the hospital, and the hospital will usually dispense 200 milligram to her. So she takes two of that in the morning, then two at night. But this time, she went to buy from a pharmacy over the counter, and they did not tell her that this is 400 milligram. You take one in the morning, one at night. So she had used two in the morning and was just calling me that, like, oh, she went to buy ibuprofen from the pharmacy. She just wanted to even confirm for me that shebi ibuprofen is two in the morning, two at night. That was actually what she called me for. And I asked her that, ma, what strength of ibuprofen did you buy? She said, that she checked, that she was gonna check it. So she checked it and told me, oh, it's 400 milligram, and she had taken two. That's 800 milligram. And she was asking me whether to take another two, because she wasn't properly counseled at the pharmacy that she bought it. The thing is, a lot of pharmacy, especially community pharmacies, just assume, like, we like to, I don't want to say we, because, and I also don't want to remove myself from it, but I think that a lot of community pharmacies assume that patients know how to use their drug. And sometimes somebody might have told them go and buy ibuprofen, and they don't know how to use it. So please, like, I'm actually saying, please, let's tell patients how to use medications when they come and buy. Sometimes it can be very somehow when you're trying to counsel a patient and they're like, oh, I know it, I know it, I know it, I know it. Recently, I don't want to say I encountered a difficult patient that I was trying to counsel, and he just kept saying, oh, the person that's going to use the drug is a doctor. And I'm like, yeah, but I'm going to still tell you how to use it. And I'm going to label it I'm going to put it on the envelope, how to use it, whether or not the person that I don't know the person that's going to use it, whether or not it's you or another person that is a doctor. I'm going to do my job. So please, this is just like something very important that we need to pay attention to. Proper patient counseling. When you give a patient of an adrenaline, tizanidine, tell them that it will make them drowsy. Like, just tell them that it will make them drowsy so that they can know not to use it and drive. Or so that they can even say, oh, because it will make me drowsy, I have an important meeting tomorrow. I can't take it in the morning. Let me just take it at night. Help them. You don't know how much you're doing when you tell patients the proper way to use their medications. So patient counseling is, and like poor patient counseling is one of the most common pitfalls that we have, and I just thought to highlight that. Another important thing I've noticed is that sometimes we make treatment decisions without fully assessing the patient. So poor patient, let's call this one poor patient assessment, excuse me, poor patient assessment. And medication reconciliation is an important aspect of pharmacy, whether in the hospital or in the community, wherever you are practicing, maybe except the manufacturing guys. But medication reconciliation is an important aspect of pharmacy that we should never overlook in clinical practice. And it's one of the most important jobs that we have to do as pharmacists. And this might also be not necessarily be to pharmacists directly. It can also apply to physicians. I've seen a patient before that came to buy medications, and she wanted to buy an ACEI lisinopril. She also wanted to buy was it losartan? She wanted to buy losartan, and I think she wanted to buy amlodipine as well. It was just very keenly. And so I just asked, I just thought to ask her, but are you the one using all of these drugs? She now said yes, that she's the one taking everything. So I was because what actually made me ask that question was ACEI, ARB in the same prescription is very questionable. I know that it is possible to. It's not advisable. I know that people use both, but there's no guideline that currently supports the use of both. I'm not even going to lie. But in practice, I've seen people use both, which I always query every time I see it. Only if the physician tells me that, oh, there's a reason, and I actually want to know the reason, right? So, like this woman, apparently, she had gone to the hospital and the doctor gave her amlodipine and I think losartan. Those were actually what were recommended to her at the hospital. But there was an outreach, there was a community outreach in her estate. And this was way before she went to the hospital. And they gave her maybe lisinopril or something. I'm not sure, I can really remember. So when she wanted to buy the drug to continue to use, when she went to the hospital, she didn't mention anything about the outreach to the doctor. So they started her on amlodipine, and I think they added losartan for whatever reason. This woman came, wanted to refill everything. The one from the outreach, the ones from that the doctor told her to buy. She wanted to be using everything. I've also seen a case where a woman was given nifedipine at an outreach, sublingual nifedipine at an outreach to bring down our blood pressure. Although that's not practice that we should continue doing. I think it has been advised that we don't do that anymore. I'm going to confirm. But this woman was given sublingual nifedipine at an outreach. She's normally on amlodipine and she wanted to refill her medications and now bought nifedipine and amlodipine, wanted to use both. It was when I was questioning her that I realized that amlodipine is actually the one she was on. Nifedipine was given to her sublingually at an outreach, but she wanted to go home and start using the two. Some patients are very funny, and honestly, so many things that you will see in clinical practice if you are very if you are very observant. I wouldn't say if you're very patient, but that would have been like tautology. If you pay attention to details, you see so many interesting things in clinical practice. And that's like these examples that I gave are valid, right? Like I was saying about medication reconciliation, it is very important to ask patients of their medication history. Ask them, prompt them, outreach, oh, church outreach, estate outreach, doctor, everybody, nurse in the community, which drugs have you used or which drugs are you using? Especially, and this is not necessarily directed to just pharmacists. I think this is also specifically directed to prescribers as well. It's important to to ask a lot of questions about patient drug history. Let them know when you are adding a medication to their list of medications. Let them know when you are replacing a medication. Like, okay, take this one, but stop using this one. Let them know and emphasize it. Because what we see in pharmacy is that they come and buy everything. The ones they have told them to stop using, the new ones you added, they just buy everything and they are using everything. And I mean, we have to, a lot of times it would lead to treatment duplication if there's no intervention at that point. It will lead to potentiation of adverse drug reactions. You see patients coming down with drug reactions that they shouldn't come down with because they are using too many drugs to do the same thing. Also, something important I want to mention before I forget is that if a patient has an history of non-adherence, you know that this patient does not adhere to their drugs. Rather than adding many, and they are maybe on like multiple medications, multiple lines of therapy, patients like this will benefit greatly from single combined therapy. You see patients like this that you know that they struggle to take their medications consistently or multiple dosing stresses them. Just give them, I'm trying not to mention because there's no promotion for any company here, but just give them one drug that has like 3 or 4 of the drugs that they are taking in one place so that they can know that once they take that one tablet, that's it for the day, right? So this is another important thing that you can do as solution. Another important thing is that, like I said, like in the beginning of this video, a treatment plan can be great on paper. Like, I'm not even gonna lie, a treatment plan can make so much sense on paper, but it does not work for the patient's reality. Because if you don't properly assess patients, this would include economic assessment, and you recommend drugs that are like high up there after the 1 week, at most 1 month dose that you give them in the hospital, they are not going to be able to buy it. That's the thing. They are not going to be able to continue to buy it, and they are not going to be able to adhere to the medication. So this, like, when you're assessing the patient, you're assessing their past medication history. You are looking out for allergies that they have. You are also assessing them economically to be able to give them something that they can afford. And for patients that are on like chronic, that have chronic illnesses and are going to be taking medications for a long time, you want to put them on a line of therapy that they can continue to use for as long as they would need it. So this is also something important that we need to pay attention to. The next point I'm going to be talking about is polypharmacy. I've kind of touched on it earlier, and this is very common. I'm putting this separately because it's very common in adults, or let's say geriatrics and elderly patients. One thing about polypharmacy is that aside that it stresses out the patient, it can potentiate interactions. And the problem that I've noticed is that a lot of times it's not that these patients need more of these medications, it is that we are not reviewing the ones they were using before. And I'm saying this for elderly patients because a lot of times I notice that elderly patients abuse pain medications. I'm not even saying it from a point of, oh, they want to be high on whatever, but elderly patients abuse pain medications, and this is because a lot of them have arthritis. And one thing is, we're not reviewing the medications that they used to use, but we just keep adding to it, adding to it. So they saw this doctor, he gave them a brand of diclofenac, they bought it. Another doctor gave them soluble ibuprofen, they bought it. Then they traveled to the US, then they got Tylenol, or they got Tylenol in Nigeria, they're using it. Another person gave them. So you now find out that elderly patients are using multiple brands. I'm not even going to lie, this is something I've seen. Multiple brands of diclofenac, multiple brands of acetaminophen, multiple brands of ibuprofen, because they have arthritis, and it's actually very dangerous. Apart from the, of course, obvious danger that NSAIDs will cause, I think that one thing is that we're not optimizing these medications. We're not looking at, oh, let's increase the dose, let's reduce the dose, let's combine this and this. What we're doing is that we just keep adding medications. We're not checking their history. Which medications have they used before, or which one are they currently using? We're just bombarding people with medications, and it's bad enough that they already have to treat so many things, right? And they're taking multiple medications for it. But let's try, like I said earlier, let's try to encourage like a combination dose system, especially for antihypertensives and anti-diabetics. I know that some classes of drug, like different classes of drug, they already come combined. And patients can just buy that and reduce pill burden. Let's also try to see that are these drugs necessary. Let's emphasize when we are replacing medications. Let's emphasize when we are adding medications just to reduce the risks and dangers attached with polypharmacy. Patient monitoring is also something that I want to emphasize in this video, especially to us as pharmacists, because patients walk into the pharmacy and refill their medication. It's very good stuff that doctors, prescribers start them on medications and they continue to use it and they're adherent and they come to us for refills. But one thing that a lot of us need to emphasize more is to tell them to go back for review of these medications. A lot of times when they go to, because I've worked in a teaching hospital before, I know that when you go to a teaching hospital, they give you a next appointment date. They say come back in 3 months, come back in 6 months. A lot of people don't go back. When they come and buy these drugs from us as pharmacists, when they want to refill, it's important that we emphasize or just ask them questions like, oh, when last did you see your doctor? It'll be nice for you to go back for a review, because it's important that they don't just continue to take the medication, but that these medications are also reviewed. You want to know if, yeah, if, you don't even know if you don't need as much as what you were using before. They might need to reduce the dose. They might need to add something else. Who knows? Like, so it's important that we emphasize this as pharmacists, especially, so that we can encourage patient monitoring. That's like one very important aspect of patient care that we usually will not pay attention to. And conclusively, as I round up, I would like to say that a patient-centered care is the most effective way to avoid all of these pitfalls. Patients counseling appropriately, like appropriately counseling your patients, reviewing medications thoroughly, involving patients in decision making, patient monitoring, and so many other things, like I've mentioned in this video, are important aspects of patient care that helps us to reduce or eliminate these pitfalls. And this is how we can actually eliminate these pitfalls in patient care, because patient care is far beyond giving the patient the drugs to use. Like I said, it is making sure that the drug is safe in this patient and it is effective in this patient. And of course, the treatment outcome would justify the reason for giving the medication in the first place. So we've come to the end of this video. If you learned anything at all, I'd like that you say something in the comment. Just let me know what you learned. And if you think that this video is what was worth your while, I think you should share. I think you should tell your friends and let everybody put them on, put everybody on. And I'll see you in my next video. Thank you so much for your time. Bye, you guys.